Good morning to one and all. So, in this lecture, I am going to deal how blood pressure can be controlled. So, the overview of the lecture is we will see how we can regulate mainly significantly arterial blood pressure, what happens to the venous blood pressure, and how we can control it, and finally, as a pathological variations, we will see different types of hypertension, also hypotension. So this is the reference book which you can follow it up. So what is actually arterial blood pressure? Normally blood pressure, denotes exclusively the arterial blood pressure, not the venous blood pressure. What is the reason? That in the subsequent slide I'll tell you. What is arterial blood pressure? Arterial blood pressure means it is the pressure which denotes the lateral pressure exerted by the endothelial cell wall of arteries. Maybe small arteries, large arteries, very particularly very big arteries, largest arteries like aorta. So it has been divided into four types: systolic blood pressure, diastolic blood pressure, pulse pressure, and mean arterial pressure. We will see one by one. What is systolic blood pressure? Systolic blood pressure means the maximum pressure. You can see it is the maximum pressure which is exerted in the arteries. Already in the early lectures, we have discussed the impact of aorta in recording very high blood pressure. So you can see maximum pressure can be present or it can be recorded in aorta and related large arteries. So maximum pressure exerted in the arteries during systole of the heart. And again in cardiac cycle we saw atrial systole and diastole, ventricular systole and diastole. Exclusively the systolic part, that too significantly ventricular systolic part of your cardiac cycle play a major role in recording this systolic pressure. So the normal systolic pressure is 120. It can range somewhere between 110 mm Hg to 140 mm Hg. It all depends upon the ages. What is diastolic blood pressure? It is minimum pressure. Systolic blood pressure is maximum blood pressure. Diastolic blood pressure is minimum pressure, again which is exerted in the arteries, which happens during diastole. Again in cardiac cycle you can see atrial systole and diastole, ventricular systole and diastole, particularly relaxation of ventricle or diastolic part of your ventricle is responsible for this diastolic pressure, and the normal diastolic pressure is average 80 mm Hg. It can range somewhere between 60 to 80 mm. The third part is pulse pressure. So, what is pulse pressure? Pulse pressure is the difference between systolic pressure and diastolic pressure, whatever it is. So, if the systolic pressure is, say, for example, 130 and diastolic pressure is 90, so you have to minus systolic pressure with the diastolic pressure where it is equal to 40 mmHg. So, similarly, the normal blood pressure is 80 120. So the systolic pressure is 120, diastolic pressure is 80. When you get the difference between systolic and diastole, you will get 40 mmHg, and this is actually pulse pressure. So pulse pressure is nothing but difference between systolic and diastolic pressures, recorded systolic and recorded diastolic pressure. What is mean arterial blood pressure? This is nothing but you have to summate the recorded diastolic pressure with one third of pulse pressure. Now here pulse pressure is 40. So what is one third of pulse pressure? So 40 divided by 3, approximately you will be getting 13 point something. We will keep us 13. So one third of pulse pressure is 13. You see what is the recorded diastolic pressure. You summate both. If in the current status, if diastolic pressure is 80, if you summate with one third of pulse pressure 13, you will be getting 93. Usually we won't consider much more about pulse pressure and mean arterial pressure. We bother systolic and diastolic arterial blood pressure. Now, what happens to the whether we are maintaining a standard blood pressure across the ages means no. You can see a newborn is recording 70 mmHg as systolic pressure and 40 mmHg as diastolic pressure, right? Contradiction to 120 and 80. So that is the normal. What we are telling is 120 as systolic pressure and 80 as diastolic pressure, right? Whereas there is a pressure variation. You can see when age grow, automatically systolic pressure is also moving up, it is rising. Similarly, diastolic pressure is also rising. And you see, you take this condition, so at least from puberty up to 50 years, right? Say almost nearing to 30 to 35 years, we have to maintain systolic pressure of 120 mmHg. Similarly, in the case of diastolic pressure, you compare this puberty to 50 years, almost for 30 to 35 years, we are going to maintain a diastolic pressure of 80. That is the reason why universally BP means we will be telling 120 as systolic pressure and 80 as diastolic pressure. Whereas when again age grow, the pressure is moving up. See, for 70 years, 120 is not normal. 160 can be accepted as normal systolic pressure. Similarly, 90 can be accepted as normal diastolic pressure. For 80 years, 180 mmHg can be accepted as normal systolic and 95 as normal diastolic. So the condition is 120, 80, this normal blood pressure applies till 50 years. Beyond 50 years, the systolic as well as diastolic pressure will change. Now, what are the factors can elevate the blood pressure? So here you can see arterial blood pressure is directly proportional to what? It's cardiac output, heart rate, blood volume. When there is an increase in blood volume, there is an increase in blood pressure, both systolic and diastolic. When your viscosity of blood increase, automatically systolic and blood pressure as well as diastolic blood pressure will increase, right? Similarly, the blood pressure is inversely proportional to two important parameters. Just you see diameter of blood vessel. When the diameter of blood vessel is decreased, both systolic and diastolic will increase. When diameter of blood pressure, when the diameter of the blood vessel got increased, both systolic as well as diastolic pressure will decrease. So directly proportional, inversely proportional, carefully you have to map it. Now we are having four different mechanisms to control the blood pressure. One is nervous mechanism, second one is renal, third one is hormonal, last one is local. Now here the nervous mechanism, you see it is totally controlled by nerves, and we have to take that as a short-term regulator. We can't totally depend upon nerves to control the blood pressure. Second part is renal mechanism. We have to take this as a long term. So we have to safeguard our kidneys. Kidney play a major role in controlling the blood pressure. So how it controls the nervous mechanism? The impulses from the from the arteries, it will move to the vasomotor center of your brain. There it will be processed, the sensory impulses will be processed, and the motor impulses again it will be received to the target organ. So totally it depends upon action potential of your nerves. Contradiction to that, in the case of renal mechanism, we are regulating the extracellular fluid of kidney, ECF volume, and there is a system termed as RAAS, that is renin angiotensin aldosterone system. RAAS, this mechanism play a major role in controlling the blood pressure. Apart from that, we are having hormone, we are having production of local vasoconstrictors and dilators, but they are all tertiary and mechanisms we can consider as tertiary mechanisms. Primarily, we depend upon renal mechanism along with the nervous, but still we can put nervous as secondary, or otherwise top 1 is renal, top 2 is nerve. So hope this will give you the better idea. We are having two important receptors to control the blood pressure through nerves. One is actually termed as carotid baroreceptor, right? You can see this is a carotid artery. This is carotid artery. This another one will be left carotid artery, another will be right carotid artery. And here you can see there is a bifurcation. So there will be one left and right internal and external. Hope you will be having a very good idea. Yes, here you can see there is an external carotid artery and there is internal carotid artery, right? So that's what here. So this will be internal carotid artery and this will be external carotid artery. So assume this could be a left carotid artery and this could be right carotid artery. So there are two carotid arteries. Each carotid artery will have a bifurcation, one external, another internal. So the baroreceptors, the nerve endings, will be very closely present in the inner wall of carotid artery. There is another type of baroreceptor present in aorta. You know, aorta play a major role. It has to maintain a blood pressure of 80, 120. So we should regulate the blood pressure in aorta also. So there is a separate mechanism to control the blood pressure existing in aorta. This is an understanding. You can see this is external carotid artery, this is internal carotid artery, this is common carotid artery. You are having bifurcation, and can you see this bulginess, right? This bulginess. So you can see this bulginess. This bulginess is actually termed as carotid body. You can see carotid body. The bulginess is actually termed as carotid body. Here you can see this is carotid body. The purpose of carotid body is nothing but clustering of cells which play a major role in controlling the regulating oxygen concentration. So when oxygen concentration is elevated, when oxygen concentration is decreased, the information will be passed to the brain and the proper motor impulses will be sent and oxygen concentration, the saturation level will be adjusted. So for regulating oxygen concentration, carotid body will take care. Whereas for regulating the pressure, you can see this the nerve endings present over here, right? That is carotid sinus receptors. They play a major role in sensing the pressure existing in the blood which is flowing through the artery, carotid artery. So that is a little bit length and breadth we will see. There is a nerve termed as glossopharyngeal nerve. This glossopharyngeal nerve or nerve 9, this will bifurcate. Now this is glossopharyngeal nerve. This nerve will branch out to another nerve termed as carotid sinus nerve. So this nerve is actually termed as carotid sinus nerve, right? And the end of the carotid sinus nerve, so very simple, it is nerve 9. So this will branch into carotid sinus nerve, and this carotid sinus nerve will create some nerve endings, and this nerve endings is actually termed as herring nerve endings, herring nerve. So you can see the receptors are nothing but they are supplied by herring nerve, or this cluster is actually termed as herring nerve. So where this is existing from cranial portion. So what is the role of this herring nerve, which is penetrating the arterial wall? The nerve endings will exposed to the blood, it will sense the pressure. Now what is the capacity, what is the sensitivity of this nerve endings, or what is the sensitivity of herring nerve? It can sense the pressure equal to or greater than 50. So it should be equal to or greater than 50. And pressure is more than or equal to 50, then this nerve ending is very sensitive. It will sense the pressure and the information will be passed to the brain. If it is below than 50 mmHg, this nerve is not sensitive. So what is the role here? You can see this is the herring nerve. This herring nerve is extended as carotid sinus nerve (CSN), and it attached or it is joined with the glossopharyngeal nerve. It is a sensory nerve. So herring nerve is sensing the blood pressure. The information, the sensory information is passed through carotid sensory nerve through glossopharyngeal nerve. It is processed in one important center termed as nucleus of nucleus of the tractus solitarius (NTS). The center is present in medulla. Right? From medulla, you can see the nerve is ending over here. The nerve is ending over here. The information is processed and then through nerve impulses, right? It terminates into thoracolumbar portion. The nerve impulses is transmitted to thoracolumbar portion, exclusive thoracic portion, T1, T2, T3, T4, right? And from there, the nerve impulses will be terminated adrenergic, as adrenergic into the ventricles mainly. You can see because we are speaking about high blood pressure, and high blood pressure already I have mentioned we have to focus on ventricles rather than auricles. So usually it will be adrenergic in nature. So when blood pressure is low, accordingly carotid sinus nerve will carry the information through glossopharyngeal, and then it will be connected to the sympathetic nervous system, and the sympathetic nerves, it will terminate as adrenergic nerves into the left ventricle as well as right ventricle, and automatically the BP will be elevated, and it is vice versa. So this is what when we want to dilate or we want to increase, whatever it is. Suppose the pressure is very high, the pressure has moved to, say for example, 150 mmHg. The pressure is very high. Automatically we have to relax the vein, right? We have to relax the arterioles mainly rather than veins and venules. We have to focus mainly on arterioles and arteries. So when pressure is very high, automatically the information is for dilation. If the pressure is too low, then the information is to constrict it. So whatever it may be, the route is very simple. Herring nerve will collect the it will measure the pressure. It will pass the information through carotid sinus nerve, and then the information is passed to glossopharyngeal nerve. It terminates in the NTS center. It is properly processed, and through appropriate neurotransmitters, it merges into thoracolumbar portion. From here, the sympathetic nerve it emerges, and then you can see this is adrenergic, and through adrenaline, either the vessel wall, the artery wall will be constricted or relaxed. So this is actually termed as nerve control. Whereas the second part of control of blood pressure is kidney. You know, kidney play a major role. The single unit, the monomeric unit of kidney is in the front. So what happens? There is two chances: either the blood pressure alters. Usually, blood pressure may elevate or blood pressure may decrease. Now here we will see what happens when blood pressure alters slowly, right? When blood pressure alters slowly for several months, years, you see nerve continuously works upon in sensing the pressure. So automatically what happens, nerve sensitivity will be lost. Right? That is the reason why we are telling nerve based mechanism is short term, whereas the long term regulation is renal based mechanism. How kidneys regulate the arterial blood pressure? Through two important things: one is regulating the extracellular fluid volume, and the second one is which stimulates renin angiotensin aldosterone system. So first we will see what happens to extracellular fluid volume. Very simple. When blood pressure increases, automatically two things will happen in kidney. Kidneys are prompted to lose large volume of water. So this is actually termed as pressure-based diuresis or pressure diuresis. So along with the water, that is in urine formation. Urine contains large quantity of water. So along with water, you will be having salts, right? Very particularly Na plus and Cl minus. So that is the reason it was actually termed as natriuresis. So along with the large volume of water, the dissolved ions, sodium, chloride, potassium, magnesium, whatever it is, but we focus much more on sodium or we bother much more on sodium, salt will be also lost. So this condition is actually termed as pressure natriuresis. So when blood pressure, arterial blood pressure increases, normally two things will happen: loss of water and loss of salt, which is termed as pressure diuresis and pressure natriuresis respectively. That is the reason why hypertensive patients are not recommended to consume large quantity of salt. So thereby we can decrease the extracellular volume. So when there is an increase in arterial blood pressure, we have to decrease the extracellular fluid, thereby we can bring back the blood pressure to normal. Now controversially opposite, suppose when blood pressure is dipped, when it is below to 70 mmHg or it is below to 60 mmHg, it's highly danger. Hypotension is highly dangerous. So at that time, reabsorption of water and the reabsorption of salt will be elevated. So that's a different mechanism, which I don't want to discuss now. So automatically, what happens? I am restoring my water volume. I am increasing the concentration of salt, and thereby the osmotic pressure will be elevated. Normally, the pressure will shoot up beyond 70, reach 80 or 85, and thereby we can maintain normal pressure. So two things you have to remember: what? When pressure increases, there is loss of water, there is loss of salt, and there is a loss of ECF. When pressure decreases, we have to increase the volume, we have to increase the salt. How to increase the water volume, how to increase the salt volume? A very simple mechanism, that is reabsorption. So through reabsorption you can increase the extracellular fluid volume, and thereby you can increase or elevate the blood pressure. But this mechanism is not that much sensitive like nerve. We have to focus on this system, which we are telling as renin angiotensin aldosterone system, right? So you can see the flow chart. We are going to discuss, we are going to take this part: decreased arterial blood pressure, right? When there is a decreased arterial blood pressure, that means lesser than 80 mmHg. When pressure is lesser than 80 mmHg, when pressure is lesser than 120 mmHg, this is systolic pressure and this is diastolic pressure. What happens? We are connecting one important organ, that is kidney. It secretes one important hormone enzyme, bifunctional. This is actually termed as renin. Don't confuse with another molecule, renin. So this is a enzyme which is secreted in gastric gland. The stomach secretes this. So renin is different from renin. So this renin is from gastric, renin is from kidney. So which part of kidney? Juxtaglomerular cells is nothing but a modified smooth muscle cells, which is which is distributed very close to afferent arterioles of glomerular, right? So juxtaglomerular cells, they are nothing but smooth muscle cells which are present very located in the afferent arterioles. They are very close to glomerulus. So this renin or this juxtaglomerular cells play a major role in secreting this renin. What is the substrate for renin? The substrate is angiotensinogen. which is converted to angiotensin 1 in the presence of angiotensin converting enzyme is angiotensin 1 is converted to angiotensin 2, and subsequently you will get other enzymes. Now here the picture is very clear. You can see kidney, it is secreting renin. Actually renin is not synthesized as such, it will be present as prorenin inactive form. This prorenin will be converted into renin in the presence of two enzymes, cathepsin B and cathepsin D. And this renin will mix with the blood, it will be circulated. When it is exposed to the hepatocytes, it will target one important molecule, that is angiotensinogen. So angiotensinogen is converted to angiotensin 1. Hopefully this is 10 amino acid decapeptide, where renin will act upon angiotensinogen. Similarly cathepsin B, where you will be getting angiotensin 1, and this angiotensin 1 in the presence of enzyme angiotensin converting enzyme, angiotensin 1 will be converted to angiotensin 2. Even cathepsin G can also act upon angiotensin 1. And this angiotensin 1, hopefully it is 8 amino acid octapeptide. This can lead to another important hormone, which is termed as angiotensin 3, and this happens in the presence of aminopeptidase A. So you see kidney, liver, even lungs also play a major role. Exclusively lungs express huge quantities of angiotensin converting enzyme. So even in the lungs this portion will happen. Angiotensin 1 will be converted to angiotensin 2 even in lungs. So three organs, the origination is kidney, load will be taken up by liver as well as lungs. Finally you will get angiotensin 2. So what is the condition? We will see there is a decrease in blood pressure. The blood pressure is decreased below 80 and below 120. We have to elevate the blood pressure. We want to increase the blood pressure. So now what happens? Automatically angiotensinogen will be converted to angiotensin 1 in the presence of enzyme renin. So as I said earlier, this is 10 amino acid peptide, and angiotensin 1 is converted to angiotensin 2 in the presence of angiotensin converting enzyme. This is actually 8 amino acid octapeptide. What is the role of angiotensin 2? This angiotensin 2 mainly involved in vasoconstriction. That means arteries will be constricted. Arteries will be constricted. Small arterioles will be constricted. As a result, the blood pressure will shoot up. Here, we want to shoot the blood pressure. The blood pressure is below 80. Say for example, it may be 65. Say for example, it may be 98. So I want to elevate 65 to 80, and I want to elevate from 98 to 120. So for this, the constriction, please recall in the early slide we discussed that the diameter of the blood vessel is inversely proportional to the blood pressure. When you reduce the diameter through constriction, the pressure will shoot up. When you dilate the blood pressure, when you dilate the blood vessel, when you increase the diameter of the blood vessel, automatically the blood pressure will down. So that point you have to take. So very successfully, the role of angiotensin 2 is to act as vasoconstriction. Now, what is the role of adrenal cortex? So we told renin, angiotensin. So we now you can understand the impact of renin. You can understand the impact of angiotensin 2. Now, what is the role of another important hormone, that is aldosterone, right? How that is done? You can see angiotensin 3, right? Here you can see. Here you can see. So two things. One is vasoconstriction, and second thing is angiotensin 2. It stimulates adrenal cortex along with the angiotensin 3, right? So angiotensin 2 is having two roles. It will decrease the diameter of the blood vessel and thereby the blood pressure will shoot up. Another important role, it will stimulate the secretion of an important mineralocorticoid termed as aldosterone, right? So the purpose of aldosterone is to increase the absorption, renal absorption of minerals, exclusively sodium. So not only angiotensin 2, along with angiotensin 2, angiotensin 3, angiotensin 4, all these two play a major role in impacting or in stimulating the adrenal cortex cells. Thereby, it will increase the secretion of aldosterone, and thereby there will be increased reabsorption of sodium. Along with sodium, all other ions will be also increased. So please recall, even under ECF, right, we have discussed, when blood pressure is low, we have to increase the reabsorption of water, we have to increase the reabsorption of minerals. So these two things are happening in the presence of aldosterone. So how aldosterone is coming outside, that is due to the presence of angiotensin 2. So how angiotensin 2 is generated in the presence of renin. So where renin is synthesized, and that is in the juxtaglomerular apparatus of your kidney. So in that way, kidney is related to heart. You see, vasoconstriction means that the arteries will be constricted and thereby the blood volume will get adjusted. Thereby the contraction and relaxation of atrium and ventricle will be adjusted. So you have to correlate all these things, right? So already in my early lecture, I would have expressed about the impact of venous blood pressure. Veins possess a very low blood pressure, right? You can see in jugular vein, it is just 5 millimil 5 mmHg. Superior vena cava has recorded only 5 mmHg. Even inferior vena cava is some 5 mmHg. Even small venules, they may record blood pressure of just 1 mmHg. Sometimes it is 0. So the influence of blood pressure, exclusively venous blood pressure, and its negative consequences is very less than that of arterial blood pressure. So we are not giving that much importance to venous blood pressure. So what is the pathological variations we will discuss? When venous pressure increases, it leads to, you can see, congestive heart failure. This is very important. Failure of valves in vein, that is very important. Renal failure. At least you have to take these three things. When you fail to control venous pressure is insignificant. Even sometimes that insignificant may be converted into significant, right? So when there is a rise in venous blood pressure, very carefully you have to monitor heart functioning and kidney function. So what happens when we fail to monitor, regulate arterial blood pressure? When somebody sees blood pressure, it denotes only arterial blood pressure. It leads to two important pathological variations. One is hypertension, another one is hypotension. We will, out of these two, hypotension is medical emergency, right? uh, Suddenly a system will collapse, a biological system will collapse, an individual will collapse, pulse rate will be decreased, the pressure will decreased, an individual will go to coma, and which leads to death. It is high critical medical emergency, right? But whereas hypertension is not like that, but still most of the population is suffering from hypertension. So we will focus our attention towards hypertension. So what is hypertension? When clinically, when there is an increase in arterial systolic pressure, when it elevates above 150 mmHg, and diastolic pressure elevates above 90 mmHg, it will be termed as hypertension normally, right? If there is an increase only systole 150 mmHg, 160 mmHg, 180 mmHg, whereas the diastolic pressure remains same 80, So now this type of pressure is actually termed as systolic hypertension. Systolic hypertension means increase only in systolic pressure. There are two types of hypertension again, primary or essential hypertension. Second one is secondary hypertension. Primary hypertension, what is primary hypertension or essential hypertension means there is no any underlying disease, there is no kidney problem, no diabetes, there is no any cardio problem, but there is an elevation in arterial blood pressure. Only elevation of arterial blood pressure was noticed without any disease. That is actually termed as primary hypertension. So this is again subclassified into benign and malignancy. So what is benign? Benign means the systolic pressure may be above 200 mmHg and diastolic pressure may be above 100 mmHg. The problem is it is symptomless or asymptomatic. The individual will not realize, will not feel any symptom. But this problem, this increase in blood pressure would have mounted years together, right? But the system, the individual doesn't notice any feeling or symptoms. So this is benign at initial stage. But what happens when there is a prolonged increase with the symptomless and the individual failed to notice it? It causes development of cardiac and renal disease. It is silent, whereas in the case of malignant hypertension, there is a rapid development of sudden elevation of hypertension within a short time period. It will not give any time for the individual to notice or to alert, to become alert, so which leads to sorry, progressive cardiac and renal diseases, where here you can see the systolic pressure is equal to or greater than 250 mmHg and diastolic pressure is greater than or equal to 150 mmHg. This is huge, which leads to severe damage of blood vessels. Small blood vessels will be damaged, leads to hemorrhage, and it is fatal disease. It will cause death. So malignant hypertension or essential benign hypertension, which is more important means it is malignant hypertension. Apart from that, what is secondary hypertension? An individual had contracted blood pressure due to other diseases, because of some disease, because of diabetes, because of cardio diseases, because of endocrine related disorders, an individual would have contracted an increase in blood pressure. That is actually termed as secondary. So here you can see due to atherosclerosis, any individual would have contracted a cardiovascular disease, nothing but heart attack. Due to atherosclerosis, an individual would have contracted heart attack. Because of that, BP would have shooted. That is cardiovascular hypotension. Because of imbalance in hormone secretion, excess secretion of aldosterone, glucocorticoids, tumor in adrenal medulla, this leads to excess secretion of adrenaline and noradrenaline. So excess secretion of mainly adrenal glands leads to an increase in blood pressure, that is endocrine. Because of problem in renal system, stenosis of renal arteries, tumor in juxtaglomerular cells, or glomerulonephritis, that is damage to glomerulus. So problem with the parts of kidney may elevate the hypertension, so that is renal hypertension. Apart from that, problem with the nerves, or there is a chance, during pregnancy there is an increase in hypertension. These are all secondary, no need to worry, very less population are suffering from this. The major is primary hypertension. So what is hypotension? As I mentioned here earlier, if the systolic pressure is lesser than 90 mmHg, not 9, even you can quote this as say, yes, so systolic means 120. If the pressure falls to 90 or lesser than 90, where a system should get alerted, that is hypotension. Hypotension is medical emergency. Again, it is classified into two types. One is primary and secondary. And what is primary? Same, there is no any underlying disease, but due to some unknown cause this hypotension has developed. So, weakness, fatigue, these are all some of the overlapping common symptoms. Fatigue and weakness, even it will appear during any infections, bacterial infections, viral infections, we will get this weakness. So this cannot be considered as a unique symptom. So persons with primary hypotension are not susceptible to heart or renal disorders too. Thank to God. Second one is secondary hypotension. What is secondary hypotension? Because of contract of some underlying diseases, because of myocardial infarction, heart attack, problem with the hyposecretion of pituitary gland, adrenal gland, tuberculosis, nerve disorders, the blood pressure would have down or dipped below 90 mmHg. So that is secondary hypotension. When compared to primary hypotension or hypertension, hypotension is not that much important. Or large population, huge population have contracted hypertension rather than hypotension. So hope you would have enjoyed this. If there is any queries, you can ask straight away. Thank you.